Good evening. Hope you are having a good day and I hope you can hear me well. Any feedback? Yes, perfect. Thank you for confirming that. Perfect. Thanks so much. Hi. I am happy to have you all here and I am your host, Caroline, and I would like to welcome you to our another webinar. And some of you probably know this, but just a quick reminder about why we are actually gathering here almost every week. So sharing is caring, as you already see it. And we are just simply here to give you not only an opportunity to get to know best doctors in the IVF field, but also to share their knowledge on many different topics on IVF treatment. And I would just like to remind you that you can find all our webinars on our site, eggdonationfriends.com/IVF-webinars. And of course, this particular webinar will be available tomorrow as well on our website. And well, it wouldn't be possible to do the IVF webinars with the help of our partners, National Fertility Society, Fertility Clinics Abroad, and Donor Conception Network. And now let me introduce you to our guest today. You already can see her. We have invited Dr. Jessica Garcia from Clinica Tambre, located in Madrid. Hello, Dr. Jessica. Hope you can hear me.
Hi.
Hi, it is good to have you here. How are you feeling
Thank you.
today?
I'm fine, thank you. I'm really happy to be here.
Happy to have you here.
Thank
And
you.
Dr. Jessica will be explaining to us the possible risk of multiple embryo transfer, but also she will give us some recommendation on single or multiple embryo transfers. And just to let you know, again, we will start with the presentation, and that will take approximately 25 to 30 minutes, and then our Q&A session will follow right after. So remember to prepare your questions. You can type them all in the chat section, and you can do it during the presentation, after the presentation, and we will publish the questions one by one while Dr. Jessica will answer them for you as well. And well, I guess that will be it from me for now. And Dr. Jessica, are you ready to begin?
Yes, thank you. Thank you so
Thank
much,
you.
Caroline.
Perfect. So go ahead.
Okay, so today we're gonna discuss the single embryo versus the multiple embryos for transfer. We will talk a little bit about the history and everything, and why are we having this question today? Okay, so first, what will we cover today? Well, we will talk about the definition, the history of IVF and embryo transfer, the new technologies that we have available to improve the embryo selection. We will see the difference, what happens when we transfer the single or the multiple embryos, and I will give you my final recommendations. So first, the definition. Well, what's an embryo transfer? Well, it's the last part of a fertility treatment. Using ultrasound for accuracy, your doctor will pass a catheter through the cervix and into the womb, like here. And the embryos will be placed here in the endometrium. So it's a really simple procedure, doesn't hurt, doesn't need to go to do it under anesthesia or anything. It's really simple. So, but the really good question that we have is the types of embryo transfers that we have. So could be the single embryo transfer, which is the transfer of only one embryo. If we have more than one embryos with good quality available, and we decide to transfer only one, is the elective single embryo transfer, okay? The double embryo transfer is when we transfer two embryos, and the multiple embryo transfer is when we transfer three or more. So this is usually we don't do this anymore. Usually the question is between 1 and 2. In some countries, they still doing it, transferring more than 3. But for example, here in Spain, we can only transfer 3 embryos or less than that. So let's talk a little bit about the history. So in 1978, the first baby through IVF was born. She's Liz Brown, and she's over 40 years old now. And well, at the beginning, it was really different, the IVF. We will use the natural cycles. So we will only recover one oocyte in each try. The egg retrieval was done by laparoscopic surgery. So it was a little bit more complicated than today. So after that, we started having new medication for IVF, and the ovarian stimulation was really improving. So we were able to have more than one oocyte. But the freezing and everything and the culture was really bad. So at the beginning, we will transfer the embryos on day 1. And what happened also, since we didn't have a good vitrification system, well, we had to transfer maybe all the good quality embryos that we have. So it was really between 3 and 5 embryos each time. So it's really, really different than today. So in 1981, we had the first twin pregnancy. And after all, we started having lots of twin pregnancies and also multiple pregnancies through IVF. The embryo transfer were changing slowly from day 1 to day 3. We were able to culture for a little bit more days, the embryos. And in the 90s, well, we were always on the news and having, we were always in the paper and everything, having all these multiple gestations, not only twins, but high order pregnancies also, 3 babies, 5 babies. So it happened in around 15 and 30% of all the pregnancies through IVF. So it's a lot. And we started looking at all the complications with that. So we started looking to try to improve that. And at the end of the 90s, we will have the first attempt to the single embryo transfer. So after that, we started having new technologies to try to improve the embryo selection, to try to improve the pregnancy rate, but reducing the risks of a multiple pregnancy. So now, what's the new trend? It's the single embryo transfer. And now we have almost 9 million babies born through IVF. So what we are having, it's a little bit of improvements, but also this. I think this is one of the most important, that we're starting trying to do the single embryo transfer in almost every country. Well, let's talk about the new technologies that we have available now. And well, I will be talking about each. We have the long culture, the vitrification, the time-lapse incubator, and the PGTA. Obviously, we have other technologies, but I will talk only about the ones that allow us to improve the embryo selection. So the long culture. Well, the culture is something like this. So we use it. It's used to recreate the environment with the fallopian tube and the uterus. So the embryos can grow just as they do inside the human body. So nowadays, the embryology labs became capable of culturing the embryos for longer periods of time in a safe way. Because in the past, it was really hard, like I told you, only until day 1 or day 2, day 3. And nowadays, we're capable of doing it until day 5, day 6, even day 7. So this is really good because now we can have these two difference. The cleavage stage, we're going to compare a little bit the embryos on day 2 or day 3, which is the cleavage stage, and the blastocyst, which is the 5-day stage, the blastocyst stage. Okay, so what we know now, since we're able to do the long culture, it's that we started looking about the embryos and the development, and we discovered that many embryos will develop initially, but then will arrest. So 50% of the human embryos will cease the development on day 3. So that's a lot. And we discovered also that when they have a really good morphology on day 2 or day 3 in the cleavage stage, a large proportion of those embryos are chromosomally abnormal. So that's why we discovered that when we do the long culture and we do the blastocyst culture, and we discovered that only the embryos with the greatest potential will achieve the blastocyst stage. We discovered also that they have more physiological synchronization with the endometrium, because what happens in the natural cycle? Well, the embryos will implant on day 5 or day 6, not on day 3. So that's why they have a higher implantation rate, higher implantation potential also. And after day 3, the genome will be activated. So when they reach the blastocyst stage, will be only the embryos with the activated genome. So that's why also it seems that we have a lower rate of early miscarriage when we do the transfer during day 5. So this is really good. This is a really good improvement. This is a blastocyst. It has over 100 cells, and this is a really powerful structure when we compare to the embryos in the cleavage stage. During the day 2 or day 3 of development, they will only have between 4 and 8 cells. So this is really, really different. So only the hardest, the strongest, and most qualified embryos will advance into the blastocyst stage. And also, if we are planning on doing the genetic testing, will be really good to do it in this stage, because it's safer and also it's better. We will have better results. So other thing that improved in the last couple of years was the vitrification system. Like I told you in the beginning, we weren't able to vitrify the embryos, so we had to transfer all of them, or we had to lose the rest of the embryos that we did not transfer. So now we can successfully frozen and thaw the embryos better than ever. So if we have a really good cycle and we have more than one embryo with a good quality and everything, now we can freeze them and then unfreeze them without losing the quality that they had when they were fresh. So this is really good. This is a really good improvement. So other thing that we have is the time-lapse incubator. This is the newest incubator that we have, and it's really good because it allows you to introduce the embryos since day 1, and you don't have to remove them until day 5 when you're going to do the transfer or when you're going to freeze the embryos. It's really good because also it's taking pictures of the embryos every 10 minutes, and then the embryologists can come to the lab every morning and they can watch a video of the development of the embryos. We can select the ones that are developing better than the rest. And also the temperature levels are really good, really stable. The oxygen levels and also the light exposure is really good because we don't have to expose the embryos to the light. So it's really good in terms to deciding which embryo to transfer first. And also it seems that we have higher rate of blastocyst when we use this type of incubator. So it's a really good option also. Other thing that we have is the PGS, or the pre-implantational genetic screening. So this is a test, like I told you, this is a blastocyst. This is it has, like I told you, over 100 cells. So this is the inner cell mass, which in the future will be forming the baby. And this is the trophectoderm, which will be the placenta and everything else. So what we do with the PGS now is we take a little bit of cells of this area between 8 and 10 cells, and we can send it to the lab, and we can receive like something like a karyotype of the embryos. And in this way, we can select the chromosomally normal embryos, and we can increase the chances of a healthy baby and reducing the miscarriage rates. And in this way, we can increase the chance of pregnancy per transfer. Obviously, we can reduce the duration of the treatments and also the number of cycles that we need to achieve the pregnancy. This won't fix the embryo or anything, but we can decide which embryo to transfer first. And also, when we have the result of the PGS and we discover the embryo is healthy, we have the highest chance and the highest pregnancy rate with every transfer. So this is a really good technology. Obviously, it's not for everyone. Who should consider to do the PGS or the biopsy of the embryos? Well, women over 37 years old, if you have the history of 2 or more miscarriage, if you have a previous genetically abnormal pregnancy, you could think about it. Or if you had multiple cycles without success, will be something to consider to try to improve the chances. Okay, let's talk about the results. Let's compare a little bit. So I know some patients will prefer to transfer more than one embryo in order to increase their chances of having at least one implanting and resulting in a pregnancy and a live birth. But also you have to consider that multiple embryos equals risk of multiple pregnancy. So 1% of also something to consider, because 1% of the implanted embryos will split into identical twins. So even when we transfer only one, we have a small, tiny possibility of it dividing and splitting into 2 identical twins. So if we transfer 2, well, we could have more than 2. We could have triplets. So it's something to consider because it happens. I saw many times in our clinic that when we decide to transfer 2, can be in the first ultrasound, can be 3. So something to think about. And well, the results, imagine this is egg donation cycles. This is from the Spanish Fertility Society from 2017. So when we compare the single embryo transfer, the double embryo transfer, the possibilities of pregnancy, 53% when we do the single embryo transfer, with only 1.3% of twin pregnancy. But when we transfer 2, the double embryo transfer, we have a little bit higher pregnancy rate, but the twin pregnancy gets so much more higher, 31%. And the triple pregnancy, 0.4%, but still a risk. So this is really interesting because maybe we can think that when we do this double embryo transfer, we will have so much more possibilities, and it's not like that. We will only increase the risks of having twin pregnancy. So this study is another study. This was really interesting because they compare using the single embryo transfer, using the PGS, the biopsy that I already explained to you, versus double embryo transfer with 2 blastocysts untested. So this is the ongoing pregnancy rate that they had in this study, and the twins and triple pregnancy rate, okay? So when they transfer one blastocyst euploid, they had 60% chance of pregnancy and 0% of twins. But what happened when they transferred 2 blastocysts untested? Well, they had higher pregnancy rate, 65%, but also the twin pregnancy was really high. Because like I told you, the blastocysts, they have a really good capacity of implant. So when we transfer two blastocysts, we have really high chances of both of them implanting. And also, like I told you, one of them dividing and having triplets. So, but this is really interesting because we can think that when we use the technology and we use the PGS to discover or to discuss which embryo to transfer first and to have a really good possibility without the risks of twins. So I think this is really good option to improve the embryo selection and to try to do it better and to be safer and to avoid this. And I think maybe you will think a little bit, well, after all the time that I have looking for a pregnancy, I won't mind to have twins or something, or even I prefer to have twins. So is twin pregnancy really that bad? Well, I think we all agree that when we look into the streets, when we are in the streets and we see a couple of twins and everything, they're super cute and everything. But you have to know that twins are not always born healthy. So all the pregnancy risks that we have in a single pregnancy, well, they increase in a twin pregnancy. So they have risk of low birth weight and prematurity. Almost half of the twins are premature, and some of them are really premature. So they can be in need of hospitalization. They can have complications associated with the prematurity. So this is something to consider. Also, the miscarriage rate is higher when we're having a twin pregnancy. And for the mother, of course, all the risks that we have in a pregnancy, well, they are higher with a twin pregnancy. High blood pressure, gestational diabetes, possibilities of pregnancy bleeding during the pregnancy, I mean, and also more possibilities of need of cesarean section. This is something really to consider. So, well, my final recommendations. Well, we have to consider first the cause of infertility because, well, it's not the same when we're dealing with low ovarian reserve, or it's different. Every case is different. So we have to consider that first when we're trying to make the decision between the transfer of one or two embryos. We have to consider also the maternal age, because when we're having a pregnancy, when we're over 40, 45 years old, we, to begin with, we already have a higher risks during the pregnancy because of the age. So I would recommend to take that into consideration when we're making the decision. Also, the medical condition. If we have another thing, for example, diabetes, or when we have high blood pressure already, overweight, underweight, something else to consider, we have to think about that because the twin pregnancy is gonna only get worse, the medical condition that we already have, and the complications can get higher. So other thing to consider is the embryo quality. Like I told you, it's really different the possibilities of having a multiple pregnancy when we transfer during the cleavage stage that during the blastocyst stage. The blastocyst have more possibilities of implant. So that's depending on the lab, the lab and the clinic. If you have the possibility of transfer during the blastocyst stage, it's gonna be better because you will have more possibilities of pregnancy. But also you have to be really careful because for the blastocyst, when we compare to the cleavage stage, of course we have more possibilities of implanting, so more possibilities of twin pregnancy. Other thing is the egg donation. We know the quality when we do the egg donation is higher, and also the quality of the embryos also is higher. And so it's something to consider because we can have more easily twins or triplets if we do the multiple embryo transfer. Also, if we decide to do the PGS, like I told you, when we have the PGS and we know the embryo is genetically healthy, we have a super high possibilities. Like I told you in one of the slides, over 60% chances of pregnancy. So this is really high. And then if we do the multiple embryo transfer, we will have really high possibilities of having a twins or triplets. Okay. Okay. So my final recommendations will be. So I think each of you, every one of you, is different, and you have to talk with your doctor and to discuss your case and everything, and your medical history, and your if you ever had a treatment of IVF or not, everything, the age, the medical condition, to discuss what's better for you. And also, other thing, to improve the embryo selection, I will recommend to you to use all the technology that we have available now to try to improve the pregnancy rates without the risks. To get informed also, and something to consider. I know we sometimes we are in a rush to have the pregnancy and we want to do it faster, but if we compare 1 plus 1, meaning one transfer and then another transfer of one embryo equals the transfer of 2 embryos. So 1 plus 1 equals 2. So the possibilities will be the same if we do one transfer first and another one after, that if we do the double embryo transfer, but trying to reduce the risks. You have to know that for all of us as your doctors, our goal is to have, of course, the pregnancy, but not only the pregnancy. The goal is to have the healthy baby at home, but also the healthy baby with a healthy mother. So that's the whole idea of doing all of this. Okay. So thank you so much. And I will be trying to solve all the questions that you have.
Fantastic. Thank you so much, Dr. Jessica, for presentation. Very informative presentation for sure, and also
Thank
for
you.
your questions. And we already have some questions, so let's go ahead with the very first one. You can type them all in the chat section, and Dr. Jessica will definitely answer, and we'll try to help you. Okay, so let's go ahead with the first question. Can you tell more about low-level mosaic?
Okay, so when we have when we do the PGS, we know that we could have 3 results: euploid, which is a healthy embryo we can transfer; aneuploid, which is totally abnormal and we don't recommend to transfer; and we could find a mosaic. So when we have the low level, also we have to consider which chromosome is implied in the mosaicism. So I would recommend to do a genetic consultation to decide the possibilities. At our clinic, we had a couple of embryo transfers of mosaics, and we have had a really good results. Normal pregnancies. So you have to consider the level of mosaicism and also which chromosomes are implied. And I would recommend you to do the consultation with the genetist to decide if it's worth to do the transfer or not, and what to expect, the possibilities of pregnancy and abortion and everything.
And thank you for your question as well as the answer. And now we do have more questions coming. So let me go to the next one. Is it still only 1% with ICSI or higher percentage?
Only 1%. Well, it seems to be only 1%. And also in the results that we have from the Spanish Fertility Society, it seems to be something around 1%. And yes.
Thank you. And let me go to the next question. It's a bit longer, this one.
Okay.
Hi, I have 3 embryos frozen on day 1, and my country does not allow genetic tests, only with special petition. Do you think it is a good idea to ship my embryo somewhere and cultivate until day 5, then refreeze it, test it, or maybe I just try to get a blastocyst and transfer it without testing? I am 42 years old and have diminished ovarian reserve.
Well, I will definitely recommend, if it's possible for you, to send the embryos to another country, maybe, and to cultivate for until the blastocyst stage, and you could do even the transfer on day 5 with the really good possibilities of the embryos that survive, because maybe not all of them are going to survive until day 5, and depending on the age that you had when you did the IVF cycle. But I would recommend, if it was over 37 years old, I would recommend, if it's possible, to do the PGS and then decide if it's possible to transfer or not.
And thank you again for your question and recommendation, and Dr. Jessica. And now let's go to the next question. So, do you recommend never implanting two, or when would you recommend two based on egg age?
Okay, so sometimes, like I told you, if the lab is not cannot culture the embryos until day 5, maybe will be good idea just to have a good pregnancy rate to transfer to, depending on the maternal age and everything, and the quality of the embryos. But sometimes you can implant two, depending on the quality and the day of the embryos. If we are talking about cleavage stage, well, we know the possibilities are less than when we're talking about the blastocyst stage. And yes, that's depending on that.
Thank you again for that question. And let me go to the next one for you. How long would you recommend a woman with 37 years and lower AMH than normal would need to wait to do the transfer? 1, 2, or 3? Would you also recommend any type of test before the transfer?
I don't think I understand that well the question. Need to wait to do the transfer.
Mm-hmm. Okay. Uh, if you could just explain a bit, perhaps, okay, because to make sure that we got it right, okay. If you Okay, I think for the IVF before the blastocyst, Alessandra added. So for the IVF before the blastocyst, okay. So let me go to the first part. Yep, that was it. So for the IVF before the transfer, so how long would you recommend if a woman with 37 lower AMH than normal would need to wait for the IVF before the blastocyst, right, to do the transfer?
Before the blastocyst.
Days, like for how many?
Ah,
Okay,
how
yeah.
many days to wait?
Yeah, exactly.
How many
So
days?
days like 1 or 2 or 3.
Well, I mean, I would recommend to wait until the blastocyst stage because, like I told you, sometimes we are afraid of not having even a transfer. But I think in all the information that we have, it supports the idea of doing the long culture because of what I told you about the embryos on day 3 or day 2, because many of them will cease the development. And I think you have to talk with your doctor also, because sometimes during day 3, you can decide based on the quality of the embryos. But I would recommend to do the blastocyst stage if it's possible, to reach until the blastocyst stage almost every time.
Okay, thank you, Alessandra, for explaining this to us and for your answer. Okay, now let me go to the next question. I had 2 embryos transferred, resulting in twin pregnancy, and had miscarriage at 11 weeks. I will have next transfer soon. Do you think it is less likely to have miscarriage when transferring 1 embryo? I am healthy, 39-year-old.
Well, it seems, like I told you, that the miscarriage rate is higher when we have the twin pregnancy. I don't know your medical history, but if you have other thing, maybe other medical issue or something, I would recommend to do more testings maybe before doing the transfer to try to avoid that and to see everything's normal. If it's and then I would recommend to transfer only one to try to have less possibilities of miscarriage. I mean, it's not that different, the possibilities of miscarriage with one or with two, but it's a little bit higher when we're transferring two. Only I think we have to be sure to make sure that you don't have anything else that's causing the miscarriage.
Okay. Thank you for your expertise as well.
Mm.
And now we already have more questions coming. Here's
Mhm.
the next one. Okay. What would you recommend for a patient after a few implantation failures, 5 failures? Is transferring to embryos recommended in this case?
Well, could be, but also, well, depending on the embryos quality, I would recommend to do first the to increase the analysis that you already did to try to see if you have another thing that is causing the failure in the implantation. I will try to see the endometrium and maybe do some blood tests just to make sure that you don't have anything else causing the failure. But the first and most important thing is the quality of the embryos. So maybe if the quality isn't that good, and we can blame on that the history that you had, maybe I would recommend to transfer to in this case if it's because of the embryo quality.
Okay, thank you as well for this answer. Now we do have another question, this time a little bit longer. Okay, let's have a look at it. Hi, I'm 45 years old. I've had 9 rounds of own egg, own sperm IVF over the last 7 years. I had implantation once 5 years ago, but this ended in a miscarriage at 10 weeks. Fast forward to now, we are doing a donor egg IVF. We did a freeze all cycle and got 6 good quality embryos from the donor egg cycle. I have since had 2 frozen embryo transfers with one top quality a blastocyst transferred each time, but both cycles negative. About to start preparing for my next frozen embryo transfer and trying to decide if I should transfer 1 or 2 embryos this time, given how many years we have been doing through this. The embryos we have left are an AA, AB, and 2BB.
Okay.
Thoughts. And thank you.
So I will recommend you to like I told the other patient, if you had 2 implantation failures already with good quality embryos, I will try to stop maybe a little bit and to decide if you need to do some more analysis, some more tests to discover if you have something else that's causing the implantation failure. So that's why all the medical history that you had in the past maybe was because of the quality of the eggs of your own eggs. I mean, because of the age. But now, since we're having two good quality blastos and also the miscarriage, I would recommend you to do more analysis, maybe to try to see if the endometrium is fine, or doing blood tests, thrombophilias to see everything is fine before doing another transfer. That's why I would recommend you to.
Thank you for this very detailed question and, of course, for recommendations. Hope that helped. And let me go straight to the next question. How successful are implantation of egg donor from a young woman at blastocyst stage versus older women?
Well, when we're doing egg donation, it seems that doesn't matter the age of the woman that is receiving the eggs. It's about the same. When we have, for instance, the egg donation when you're 30 or the egg donation when you're 45, we have the same implantation rates, meaning that sometimes the results, sometimes in the pregnancy rates, when we're using our own eggs, is because of the quality of the eggs. But when we change that and we do the egg donation, and we have, of course, good quality eggs since the beginning and good quality embryos, well, we have the same possibilities. Even when if you're 30 or 45, it's the same.
Perfect. Thank you again for that. We also already have more questions coming, so let me go ahead with the next one. Do you often do hysteroscopy before the transfer? Does it higher success rates?
Well, we usually don't do it unless it's indicated. I don't think we do it only in special cases when we are having, for instance, implantation failure, and we try to see if everything's normal in the cavity, because sometimes with the scans we can miss a couple of small things such as adhesions or polyps or something. But to begin with, we don't do it in every patient. No, only if it's indicated.
Okay, thank you. And we have a bit more detailed question right now. Let's have a look at it. I just removed uterine adhesions scars from a myomectomy 5 years ago. The doctor mentioned 20 to 30% damage on walls. Can endometrium recover its damaged parts, or the embryo will need to find a way to implant on the other 70% remaining area? Do embryos move around to get a better place implant?
Well, I think sometimes, depending on the damage, the endometrium can recover a little bit, and the embryos don't move around to get a better place. Maybe just in the area where they are left during the embryo transfer, but they don't move more than that, just a little bit. So I think you have good possibilities of the endometrium recovering. Maybe you have to wait a little bit after the surgery, and then to see if you have issues when you are doing the endometrial preparation and everything. Then you can see, for instance, if you have issues when when you're doing the endometrial preparation, maybe you will notice, or maybe it's going to be because of the surgery, and we can discover if that the damaged parts are
All right, thank you. And let me get to the next question for you. Can you please explain the difference between ERA, ALICE, and EMA tests? How reliable are they?
well, the ERA test allow us to see the endometrial receptivity, so we can discover how many days of progesterone do you need, and if it's like the average woman, of if you need more days, less days, to see the implantation window. And when we're doing the ALICE, it allows us to see if you have chronic endometritis. It's like an infection into the endometrium, and we can decide if you need to take antibiotics or something. It seems that the chronic endometritis can cause abortions and implantation failures, so it's really good. And the EMA test will allow us to see if you have the normal microbiota into the endometrium, or if you have to take a couple of probiotics or something to try to improve the flora in the endometrium. And it seems they are really reliable. We had really good results in our clinic when we use the ERA. It's not for the endometrium, I mean, the three of them. It's not for everyone, but we're having really good results when we're using it. And also in the studies, it seems to improve the implantation rate and to be really good.
Perfect. Thank you for explaining us the difference between those tests. And we will be slowly finishing. So I am sure you do have more questions. So go ahead and type them all in. And now let's go to the next question. Are there any studies confirming that doing genetic testing of donor and partner whose sperm will be used to confirm the matching?
Well, yes, we have something called genetic matching, which allow us to detect the recessive illnesses, and we can do the matching within a couple or between the donor and the partner to see if they match. What happens with this test? Well, we can test over 300 recessive illnesses, and to see if they match. What happens if they have the same disease, the same recessive illness? Well, we can change the donor to try to find another one and to do the matching again to try to find one donor that matches with the partner, and in this way to reduce the risks of having a sick baby.
And again, thank you so much for explaining this to us. And there is another one for you right here. If a polyp has been found in the cervix when having a scan before the transfer, will this cause a problem for the transfer?
Well, usually it won't, because it seems in all the information that we have that all the polyps inside the cavity and inside the endometrium can cause and can cause a failure in the implantation or reduce the possibilities of implantation. So if the polyp is in the cervix, I don't think it's gonna be more issue than that. Could be that we have a little bit more difficult implantation, could be a little bit more difficult transfer, but just at the beginning, and then will be normal. So I won't worry about that.
Okay, and thank you again for the explanation. And there is another question for you right here. Do you have experience in your clinic with embryo implantation despite adenomayomas? Are implantation windows different? What about miscarriage prevention? What do you recommend to do in this case?
So, oh, thank you. So we have lots of patients with adenomayomas, and we had a really good result. Doesn't seem to affect the implantation window. We obviously don't have that many patients with the ERA, for example, and the adenomyosis. So it doesn't seem to affect that. Sometimes, if it's too severe, the adenomyosis, we can use agonist of the GnRH to try to avoid a little bit the consequences of the disease. But we're having really good pregnancy rates, even though with the adenomyomas. And we don't do anything different in this case to prevent the abortion. Is usually we do the same protocol, unless we have a really good severe disease. Then we have to do a pre-treatment before we do the transfer to try to reduce the, the disease and the effects of the disease in the endometrium.
Okay, perfect. Thank you for the answer for this one as well. Again, let me remind you, this will be like our final call for the questions. So if you have any left, go ahead and type them all in. And now let me have a look at the next question for you. Till what week of pregnancy do you give progesterone?
Well, till week 10 of the pregnancy. This is very controversial. We know that the placenta starts producing the progesterone from week 6, from week 7. So usually we keep it until week 10, just to be safe. But we know that the placenta will start producing the progesterone earlier, until since week 6 or week 7. So
Okay, thank you for that answer as well. And I can see someone is typing, so let's give it a minute so to see if we have any more questions. Yes, we do. Let me go straight to this one. I wanted to ask my doctor for a few information checkup and immunological tests. I was told we have just too many tests. Which ones would you say are the most basic ones?
well, we always check the antiphospholipid syndrome analysis, and also the factor 5 of the coagulation, and the factor 2 of the coagulation, the protein S, and the protein C, and also the C3, C4, and we check also the intolerance to gluten. And I think that will be, maybe I'm forgetting some, but I think that will be the basic immunological test.
Okay, thank you. And we have a follow-up question. Are they all blood tests?
Yes, yes, all blood tests.
Okay, perfect. Thanks for that. And okay, we have 2 more questions, but of course, if you have any others, go ahead and type them in. Okay, here's the next one. Are there any tips or advice you can give for what to do after a transfer? And this will be my first one. Should I fly soon after or the day after?
Well, in all the information that we have today, it's not recommended to do anything else. You will do the transfer and then you will rest a little bit, just maybe 20 minutes or something, and then you can do a normal life. I will recommend you can fly even, that's okay. I will not recommend to take immersion baths, to be in the pool or anything, or to have to get into the sauna. I will recommend you to have to don't drink alcohol, don't smoke, and everything, like all the care that you have when you're pregnant. I would recommend you to do that. But besides that, you don't have to do anything else, because it's not proven that having rest after the embryo transfer will increase the chances, or that it's necessary really. So I won't recommend you to do anything else than that.
Okay, perfect. Thank you for that advice as well. And now we have another question. Do you think that ICSI increases chances of pregnancy?
Well, it doesn't seem so. When we compare the IVF, the regular IVF, with the ICSI, it seems to be the same, about the same results. So only sometimes we're a little bit scared that when we do the IVF, we won't have we will have a failure in the fecundation. That can happen in very rare cases. That's why I think we almost in every clinic they do almost in every case the ICSI, but it doesn't seem to be better. It seems to we have the very similar results. It seems to be the equal chance of pregnancy with both.
Okay. Thank you for this explanation as well. Now we have a follow-up question again, and here it is. In follow-up to my initial question earlier, you mentioned that I should look at other investigations before my next frozen embryo transfer from
Mhm.
donor. I have had hysteroscopy, aquascans, Chicago Immunes, blood tests, ERA, blood clotting tests. I've also had just the EMA test and await the results. Seems I've had every test available. Is there anything else you would suggest before my next frozen embryo transfer?
Well, maybe we have to wait until we have the results of the EMA. It seems that you already did everything. I think sometimes in some cases we don't know the cause, maybe because the science is not there yet sometimes. I will wait until when you have the results for the EMA test, and then if everything is normal, well, I will decide. Sometimes we're also talking about possibilities, because when we're doing even a egg donation, is not 100% possibility, never. And sometimes could be in having just because of possibilities, we could not be reaching the pregnancy. But I think you already did everything that's possible now. So I hope you have a really good luck in the same transfer.
Thank you for that advice. And we already have one more question. And let me go to this one as well. What is a good endometrium line, and what do you need to see in the ultrasound exactly to say this is a good endometrium and it is well prepared to receive the embryo?
Well, it has to be perfect. It has to be over 8 millimeters, and also it has to look well to be triple lining. We see actually like a triple lining into the scan, and it's very, very clear. And yes, that will be a really good endometrium to have.
Thank you. And we have, okay, here it is, the next one. Do you check the endometrium before transfer, and what is the minimum millimeters you recommend, right?
Well, we do check the endometrium before the transfer, and the minimum will be 7 millimeters. Of course, some patients have really a lot of issues to prepare the endometrium. Sometimes we have to accept the transfer with less than that, but that's really rare. Nowadays, we have lots of therapies that we can use to try to improve the embryo lining. And well, at least I would recommend to have at least 7 millimeters. If it's possible, more than 8 will be better because it seems to improve the pregnancy rates when we have more than 7. But I think in some studies, they found some pregnancies with 3 millimeters of endometrium. So it will be better to have more than 7, but sometimes it's not possible.
Okay, thank you. And I believe there are like 2 questions left, and so this one is actually similar. Is there a maximum millimeters recommend acupuncture before and after transfer?
Well, we will recommend you to have more than 14 millimeters. And about the acupuncture, well, I don't think we have information in the studies available to that the acupuncture will improve the pregnancy rates, but also it won't hurt you. So if you want to do it, it's fine for us. We can try to do it. It won't hurt you, and it won't reduce the pregnancy rate. So if it works, better. If not, it's okay. Also.
Perfect. Thank you for the question and your suggestion here as well. And there's another question, as I've mentioned, that I believe will be the last one, unless you have some other questions. Here it is. My lining thickness up quite well with the progesterone preparation, but there is often no triple layer seen. My clinic does not seem overly concerned that the triple layer is not seen and are more concerned with the thickness. Do you think the triple layer is more important than thickness? Have you seen success in ladies who don't have the triple layer appearance?
Well, it seems to be really important also. I think the millimeters are more important also, but also the appearance of the endometrium is really important. The truth is that sometimes some patients don't have the typical triple lining because the uterus is not in the regular form. Sometimes it's in one side, in another side, in different position. So sometimes it's not that easy to see the endometrial lining, the triple layer. But if we see it's over 8 millimeters, and we have the progesterone test done also, and it's almost 0, so we can be a little bit we can be relaxed about that. Sometimes we cannot see the triple layer also.
Okay, thank you. And in the meantime, we did receive another question. Okay, it will be the last one. Let me show you this one. Do you see any connection between psychological state, any success rates?
Well, not really. And also in the information that we have, it seems obviously that it's not the cortisol levels when you are stressed and you are sad and you're depressed. The cortisol levels are higher and could have a little bit of implant or a little bit of the word could a little bit of impact when you have the cortisol levels super high and everything, but doesn't seem to reduce drastically the pregnancy rates or anything. So I think I don't see the physiological safety affecting the success rate that much, or I don't think so.
Okay, thank you for explaining this. And we have a follow-up question here. Do you think being on antidepressant medication can affect IVF outcome? Do you see success with ladies who stay on their antidepressants during IVF?
I would recommend you to stay in the depressant if you need it. It's okay. I don't think it's gonna affect the result. And like I told you, the information that we have is not going to affect the result. And I think it's really important to be okay and to feel good when you're doing the treatment. So I would recommend you to stay in the treatment if it's possible to do it, because you have to sometimes change a little bit the antidepressant to find one that is not affecting the pregnancy, so that you can use after the transfer and everything. You have to see that. But if you have it, I will suggest to keep it, because I think you have to be feeling okay when you're doing this kind of treatment. And yes, I don't think it's going to affect your success.
Okay, perfect. Thank you so much for giving us this advice as well. And we do have another one, another question. It's again a follow-up from a very same patient. So let's have a look at it. Could you help me to transfer my day one embryo to your clinic so we can try to reach blastocysts and do the genetic tests? Is this something you normally do? They are in another European Union country now.
Well, I mean, yes. Of
Mm-hmm.
course, we have to see the country and the other clinic, and well, yes, we can keep the contact. You can keep our contact, and I will try, yes, to do it. And it depends sometimes on the clinic and everything. We have done it in the past, and yes, I think we can do it.
Okay, perfect. Thank you so much. And just to let you know, of course, we can definitely connect you with the Clinica Tambre. They will get back to you and provide you with all the details, necessary details on how it would work, etc. So you can also drop us an email, and we will forward this to the team as well. Okay. And I believe this was our last question, but as someone is typing, I just want
Mm.
to give it a minute. I do see those are probably shot outs, but let's have a look at them. There are many thank yous already, so I would
Oh,
like you to see it. Here it is, more coming. Thanks very much for your answers. It was very interesting. Thank
mm,
you. We are happy to help you. Thank you for all your help. And it's always
mm.
good to have a look. Muchas
Oh.
gracias. Thank you so much. So we are
Oh.
happy to that you found it informative. Okay, and so one more time, thank you so much, Dr. Jessica, for your time today, for joining us. It was a great pleasure to have you here. And once again, huge thank you for the for our attendees for your questions, very detailed
Oh,
ones
thank you.
sometimes, and for joining us here again and again as well. Um, just to let you know, as I mentioned, there are more thank yous coming here, so
Oh.
we are happy to assist for sure. And feel free to subscribe to our YouTube channel so you will be updated as soon as the video is uploaded on the site. Plus, you can follow us on our Instagram, our Facebook page, and you will be, I am sure you'll find lots of interesting information. And Dr. Jessica, perhaps you would like to add something. You have some comments.
Well, I want to say thank you, all of you, for being here. And I hope it was interesting to you and you learned something. And thank you. That's it.
Perfect. Thank you. That's it's good to it was definitely good to have you here. And one more time, Many thanks to you, Dr. Jessica, and to you all. Hope you will have a good evening. And well, that would be it for today. Thanks so much. Thank you. Bye.
Bye.